Oh, Perla, what have you done?
Oh,
I'll
you've
go
back.
I can see my face a lot. Dr. Perla Eleftheriou is going to go through chelation in haemoglobinopathies. So any questions, if you put them, your hand up or in the chat, and myself or Amina will keep an eye out and try and make sure that you're answered, because I don't think you can see the hands raised, can you, Perla, when you're in presentation mode?
Can't. Yes.
Okay,
Yes.
so we'll keep an eye on questions. So yeah, so over to you.
Great. Thank you very much. Good morning, everyone. Yes, I'm Perla Eleftheriou, hematology consultant at UCLH. Can I just double check? Is the majority in this meeting today from the nursing staff? Or do we have a mixed bag, clinicians and doctors and nurses?
You can all just pop in the chat or speak and just say what your role is.
Or perhaps just to not to waste more time, Bernadette. I was just wondering whether you saw the names and whether you recognised. That's fine. It's okay.
Perla, I'm looking at attendance, and it looks like there's a mixed bag here of nursing staff and consultants.
Perfect. Okay, great. Now let me minimize that. Oops. Right. So tell me if you can still see my slides. All good?
Yes.
Perfect. All right. So let's talk about iron chelation. So the next few minutes, or during the next I think it's going to take about 45 minutes, this talk. We will be talking about the challenges of iron overload and the benefits of long-term chelation, the role of monitoring in optimal outcome, and the importance of dose optimization, taking into account the rate of iron loading and the level of iron overload. And then we're going to talk about specific challenges. So, for example, how we manage the low iron burden, what the best way to adjust chelation would be in this situation, and then talk about the role and principles of chelator combinations. So if we want to start with the challenges of iron overload and benefits of long-term chelation, let's just quickly remind ourselves that through transfusion, in an average transfusion,
You've got to mute, Perla.
Oh my goodness, have I been on mute all the time?
No, you weren't, but you need to go back to the beginning of this slide. We'll start again from here.
Fine. So just to remind us that in an average transfused thalassemia patient, the influx of iron, the daily influx of iron, is about 20 to 40 milligrams per day. And if you translate that into milligrams per kilogram per day, that's it sits in the range of 0.3 to 0.6 milligrams per kilogram per day iron through the transfusion. So this is the range capturing the majority of our transfusion-dependent thalassemia patients, and there will be some who will fall into the range of less than 0.3 or more than 0.6 milligram per kilogram per day. So this iron will be distributed to the various places to do what it has to do and help with erythropoiesis, and some of it will be stored in the macrophages, and in the plasma it will be circulating in the form of transferrin bound iron. But because we are dealing with a situation where we are transfused in a thalassemia patient more iron than what can be excreted to achieve the equilibrium of iron in the body, we end up with non-transferrin bound iron, which is exactly the toxic form of iron which can cause organ damage, that is to say hypogonadotropic hypogonadism through the deposition in the hypothalamus and pituitary gland mainly. It can cause hypothyroidism and hypoparathyroidism, myocardial iron overload, leading to heart arrhythmias and heart failure. liver fibrosis and cirrhosis, as well as an increased risk of hepatocellular carcinoma, diabetes mellitus, but also exocrine pancreatic insufficiency and hypoadrenalism. So all those are well-recognized complications of iron overload, predominantly caused by the oxidative damage through the non-transferrin bound iron. So this is a slide to show you the reduction in iron overload related mortality in the UK over the years, and you can see here the most important milestones in the management of thalassemia and beyond. So in 1970s, this is when the regular transfusion became the norm in the management of thalassemia, and you can see that before that, the majority of the patients, that is to say the bars in pink, the majority of the patients were dying from anemia. But then through the introduction of the transfusions, of the regular transfusion regimes in 70s, the anemia mortality reduced, and we started seeing more iron overload now mortality. So that those are the bars in red. In 1980s, the desferrioxamine therapy became the standard of practice. And then what really changed the game was the introduction of the cardiac T2 star, which was introduced in the UK in 1999. And you can see that since the introduction of that and the parallel approval of deferiprone in Europe, the reduction of the iron overload mortality has significantly decreased, and even more so since 2006 when the deferasirox was approved in Europe. So you can see now the last bar on the right that the majority of the cases of the mortality cases are due to non-iron overload related problems, that is to say infection or hepatitis C complications. And remember that previously blood was not screened properly for hepatitis C, and that's why we now in those older than 40 we see a lot of hepatitis related complications. So let's go and talk about the role of monitoring. Why is it so important to monitor the iron overload? Obviously, this is to minimize the organ damage and to recognize the early trend of iron overload, because we can identify those who are not adhering to chelation properly and advise accordingly and monitor more closely. To identify non-responders to chelation regimes, there are patients who don't particularly respond to particular chelation regimes as well as with others, and to identify patients at increased risk, for example, those with high myocardial iron. So if we pick those, we will change in the right time fashion the chelation combination or regime to tackle the particular complication, that is to say heart failure or arrhythmias as a consequence of high myocardial iron. And the other reason why we should monitor iron overload carefully is because we want to minimize the risk of overchelation, is to minimize the risk essentially of side effects from chelation as well. So can the risks of overchelation be decreased by monitoring the levels of iron overload in different tissues? And we need to know when to stop or reduce dosing for soft landing. So what do we have in our hands to monitor iron overload properly? So we have the iron loading rate. So we should be able to calculate this knowing the transfusion requirements of each individual patient. So therefore, knowing that, we know whether we're dealing with low iron loading patients or medium iron loading patients or high iron loading patients. And this is very important for us to know how to adjust the chelation. But at the same time, of course, we have the serum ferritin. We have the R2 relaxation method by FerriScan to measure the liver iron concentration, and we have the myocardial T2 star, which measures the myocardial iron content. And then we have other biomarkers. Some centers do them, some others don't. Some of them are experimental. So at UCH, we do measure NTBI, not as part of standard of care, but we can measure them if we want to, as well as labile plasma iron. And of course, we monitor the adherence by having frequent conversations with the patients. So this is showing you the iron loading, the natural course essentially of the iron loading rate in transfusion-dependent thalassemia as well as in non-transfusion-dependent thalassemia, and you can compare it with the hemochromatosis patients. So the orange bar on the x-axis is normal liver iron. So on the x-axis you have the age, and on the y-axis you have the liver iron content. And you can see that a normal liver iron content by FerriScan would be up to about 2 milligrams per gram dry weight. And everything above 7 is really considered associated with increased risk of iron-related morbidity. And you can see that over the very rapidly in transfusion-dependent thalassemia patients. So the curve on the left, so in dark blue. So very early on, already by the age of 20, if we don't chelate properly these patients, they will accumulate significant amounts of iron in the liver associated with early mortality. And you can see that, sorry, there's some background noise. And you can see the dotted line represents a non-transferring thalassemia, non-transfusion-dependent thalassemia patients, so the thalassemia intermediate patients. So you can see that despite the fact they're not on regular transfusions, they are loading iron with the time, and you can see that how by the age of between 40 and 50, they would have accumulated, the majority of them, respectable amounts of iron in the liver above 20 milligrams per gram dry weight. And you can see that the hemochromatosis patients sit somewhere in between. But this is one of the take-home messages, that transfusion-dependent thalassemia patients do need regular iron monitoring as well, because they will be loading iron despite the lack of transfusions. So now let's talk about the ferritin. So the ferritin assesses the body iron stores, which mainly is in the macrophages. So it's useful when we look at the trend of the ferritin, because that tells us in the majority of the cases the trend of the body iron stores. So that gives us an idea about compliance, about whether the dose is right, or whether the regime, the actual chelation they're on, is right. We know from studies that in transfusion-dependent thalassemia, patients sustained values more than 2,500 micrograms per liter predict long-term heart risk. And also what we know is that if the ferritin is very low in somebody on desferrioxamine, we can see increased desferrioxamine toxicity. What's the target level? We say that in regular transfused and chelated patients, we should aim for about 1,000 micrograms per liter with desferrioxamine, perhaps a bit lower with combination therapies, and about 500 micrograms per liter with diferasirox. So we need to appreciate that obviously ferritin is not reliable as a single tool of iron loading monitoring, and that is very unreliable as a screen or monitoring tool in non-transfusion thalassemia dependent thalassemia patients. So it underrepresents the total body iron stores in the non-transfusion dependent thalassemia patients, essentially. So you can have a normal ferritin, but if you do a FerriScan, you will find potentially an increased liver iron content. So we have to bear that in mind. So if the ferritin trend is increasing, then we need to focus on the adherence. We need to consider dose increase or change of the chelation regime, but also we need to look at other things which make the ferritin go up. Remember, it's an acute phase protein, so therefore it will rise in the presence of any infection or inflammation, whether those are chronic or acute. Classically, in our patients, when we see the ferritin rising, despite the fact that we think they're very compliant with the chelation, and especially if you do a ferry scan and the ferry scan shows normal liver iron contents, then you need, or not normal but stable or not increasing liver iron contents, then we need to question whether they have increasing liver disease in the form of fibrosis or cirrhosis, or underlying hepatitis C, or fatty liver. All those conditions which increase inflammation in the liver can cause a rise in the ferritin in the absence of true increase of the total body iron stores. Now, if the ferritin trend is decreasing whilst on chelation, if this happens rapidly, then we need to adjust. We need to be careful and adjust the dose to minimize the risks of overchelation. If the levels are already low, then again we need to fine-tune the dose, reduce a little bit to potentially, depending on how much they are, to allow the maintenance of the current low level rather than letting it drop lower. So the correlation between the ferritin and the liver iron content is really pretty much all over the place, but it's much better when the baseline serum ferritin is less than 4,000 micrograms per liter. So if you're dealing with patients who have ferritins above 4,000 micrograms per liter, really, even looking at the trend, that doesn't tell you anything about the iron stores. There's pretty much no correlation. So some of these, what I have in this slide, I have just mentioned as well, just now. So we cannot just use serum ferritin for iron loading monitoring, because it's raised by inflammation or tissue damage, and also it's lowered by vitamin C deficiency. So why do we assess and control liver iron? So because of what we just said, so the ferritin alone may not reflect the true body iron and chelation trends. So the liver iron content trends are more reliable than the ferritin trends. And the liver iron content trajectory is especially useful if the ferritin trend is not responding. So sometimes you might wonder, have this patient on a great dose of so-and-so chelation, and they are actually taking it. I know the patient, they're telling me the truth, but the ferritin is stuck. When you actually measure the liver iron contents, you might often find that actually the liver iron content is decreasing. And this is when you have to reassure your patient who is already anxious and thinking that everything they do in terms of taking the chelation is in vain. We know that the liver iron content predicts the total body iron store in transfusion-dependent thalassemia, and there are studies which have shown that precisely. We also have to monitor and control the liver iron carefully, because we know that too much iron is associated with liver pathology. We know that it increases fibrosis risks and cirrhosis risks and hepatocellular carcinoma. Therefore, we have to also monitor not just the liver iron content, but the liver enzymes carefully. And we know that there is a correlation between liver fibrosis progression if the liver iron content is above 16 milligrams per gram dry weight. Now, we also know that increased liver iron content is linked to a high risk of cardiac iron in unchelated patients. And we know that a liver iron content above 15 milligrams per gram dry weight is associated with an increased risk of cardiac death. What other measures do we have apart from the ferry scan, which measures the R2 in the liver and gives you an accurate liver iron content? What other approaches do we have? We know that we can biopsy the liver and measure the iron. However, this is not a great way of measuring the iron because of obviously the invasive nature of the procedure associated with risks, but also you need a decent sample to make sense out of that biopsy. And we know that the iron distribution in the liver it's not homogeneous, and therefore really the biopsy can be unreliable in terms of the particular measurement of the iron in the liver. Although from the biopsy you can gain information probably the best information about the texture, the pathology of the liver tissue, whether there is fibrosis or cirrhosis and to what extent. We can measure iron in the liver through the T2 star modality. However, the T2 star calibration underestimates the liver iron content, and the R2, the ferry scan, is much better standardized and very easy to introduce to the thalassemia centers. So why not just measure ferritin and liver iron content? So we know that while sustained high levels of ferritin and or liver iron content, this increases the risk of myocardial iron. So some patients do not have myocardial iron despite sustained high LIC and ferritin levels, and some patients have high myocardial iron despite low current levels of ferritin and LIC. So there's this discordance. So we can't say, yes, your liver iron is increased and therefore you definitely have increased iron in the heart, or we can say your liver iron content is low and therefore you don't have iron in the heart, because you see patients who have one and not the other, and therefore you do have to do both. Now there is good evidence of the relationship of myocardial iron measures, so the T2 star, and the risk of heart failure in the near future. So the cardiac T2 star MRI estimates the myocardial iron. We know that T2 star values less than 20 milliseconds are associated with increased myocardial iron and decreased LVEF. And cardiac T2 stars of less than 10 milliseconds are associated with increased risk of heart failure in the next few months. So we need to target for a cardiac T2 star above 20 milliseconds. This is what is considered normal. And what we recommend is yearly screening if they are regularly transfused, and more frequent if the cardiac T2 star is less than 8 milliseconds or they already have low ventricular ejection fraction from previously iron overload in the heart. And when I say more frequent, that is decided on a case-by-case basis, but I would say every 6 to 8 months is good practice to do that in those patients with severe cardiac iron overload. But bear in mind that the cardiac T2 star is not a surrogate marker of risk to the liver, and if we are, as we said before, and if we are going to use a T2 star, it must be done with a validated standardized method. And there are a lot of cardiac T2 star scanners around in the UK as well as internationally, which are not well standardized, so that needs to be looked at. So well-established relationship between cardiac T2 star and cardiac failure. We know that those with so the lower the T2 star is, the higher the risk is to develop cardiac failure early on, and we know that values of less than 8 milliseconds and in particular less than 6 milliseconds are the most problematic ones. So let's go and talk about the importance of dose optimization for the rate of iron loading and for the level of iron overload. Chelation is currently licensed desferrioxamine, diferriprone and diferasirox. So let's take desferrioxamine first. Usual dose 25 to 60 milligrams per kilogram per day. It can be given subcut or IV over a certain amount of hours a day or 24 hours a day, depending on what we're dealing with. Classically, in somebody where we want to maintain a good body iron store level, we would prescribe it 8 to 12 hours subcutaneously, 5 to 7 days a week. The half-life of desferrioxamine is very short, 20 to 30 minutes. That's why it has to be given as an ongoing infusion, and it is excreted in the urine and in the feces. It's a very well-tolerated drug. Yes, it can cause some local reactions sometimes, or in the majority of the cases, we can tackle those, adjusting the volume they're receiving, but also potentially with Piriton and hydrocortisone in the infusions. But the main thing we need to look at is growth problems in young children. So if we give them high doses, we can affect the skeletal formation. And the main worry in the adults is the ophthalmic and auditory toxicity. So it can cause hearing as well as vision impairment. Going to the differiprone, the usual dose is 75 to 100 mg per kg per day. It's an oral drug and has to be given three times a day because the half-life time is 3 to 4 hours. It's excreted in the urine, and usual side effects are gastrointestinal disturbances. But the main worry is the risk of neutropenia and agranulocytosis, which sits in the range between 0.5 and 3% if you combine the two together. The differasirox, 10 to 20 milligrams per kilogram per day. So we have the new formulation, the film-coated tablet. So it started with the dispersible tablet for many years until 2017, when the film-coated tablet was introduced, and now we have generic differasirox. So up until about a year, we had the XJade, but now there are a lot of different generics on the market. So you've got to be careful what generics you're using and monitor your patients on the generics. There should not be any difference because it's the same drug, but especially in the first year of transition, I would say it's good practice to keep an eye on how they're doing. So it's given once a day. This is the beauty of the differasirox, because it's not a subcut infusion. It's not a tablet which you have to give 3 times a day, but it's a tablet that they can have once a day. It's not one tablet, of course, because it's milligrams per kilogram, so it depends on the patient's weight, but they only have to take it once a day, whatever amount of tablets they have to take. Half-life, it's the longest from the 3, so it's 8 to 16 hours, and it's excreted in the feces. And therefore, bear in mind that some of them who were on desrioxamine or differiprone before and could see their urine stained, red, have this reddish color because the iron is excreted through the urine with these chelators, will be very skeptical when they're switched to differasirox and the urine is clear now, and they will be thinking that they're actually not achieving iron chelation. So you need to reassure them that the reason the urine does not appear to be reddish anymore is because the iron is excreted in the feces and not in the urine. So usual side effects of differasirox are gastrointestinal disturbances, so nausea, abdominal cramps, vomiting, some diarrhea, but those used to be more of a problem with the dispersible tablet and less so much of a problem now with the film-coated tablet. So it can cause rashes, and the main, which we usually, if you persist with the dose or you lower it and you gradually build it up again, usually the rashes resolve. The main worry is the renal dysfunction. So about 30% of the patients will develop at some point a degree of renal impairment, so a rise in the creatinine or a rise in the urine protein creatinine ratio, being on the differasirox, and this is what we need to focus on in terms of monitoring those patients on this drug. So all patients should be monitored regularly for their transfusion rate, for the iron overload status by all those tools that we've just mentioned, for the treatment efficacy, patient compliance, growth, in particular, obviously in the pediatric population, and for adverse events. The chelator treatment should then be adjusted according to all above, and it's never the same for a long time for any patient. If we do it properly, you will find that there will be a lot of ups and downs in terms of the doses and often in terms of the actual nature of the chelation. So really, it's just to show you again that we have to always achieve this balance between not too much chelator to avoid toxicity and enough chelator to avoid too much iron to prevent organ damage. So the transfusion rate is the primary consideration when initiating chelation therapy in a transfusion-dependent thalassemia patient. And this is important for the pediatric patients when we start them on transfusions, but also later on in some of our non-transfusion dependent thalassemia patients who will end up needing transfusions at some point in their lives. So it's important to see what the transfusion requirements are and initiate a sensible dose of chelation. So yes, this is another graph or table showing you what I just said, the importance of transfusion rate in response now to particularly, the divarasib dose. So you can see that in a dose of about 10 milligrams per kilogram in a high transfusion dependent patient, so the pink box there. So that is to say those who receive more than 0.5 milligrams per kilogram per day iron through their transfusions, these will not achieve, a dose like this of divarasib will not achieve anything, will not achieve a negative iron balance. Whereas in a low transfusion dependent thalassemia patient, so the green box, yes, a third of patients will be in a negative balance on this dose. So just to understand that, we're not randomly selecting the doses for each individual patient. When we start the chelation, we've got to, but also later on when we monitor the patient, we have to look at whether the transfusion requirements are changing. That will help us, together with the other tools we have in our hands, to adjust the dose accordingly. Yeah. And you can see here how increasing the dose basically increases the percentage of patients who go into negative balance. You see the red box, the pink box, how increasing the dose increases the percentage of patients who achieve negative iron balance. So iron levels should be monitored regularly, and in the case of high on treatment iron, as measured by persistently elevated liver iron content by FeriScan, and or persistently elevated myocardial iron by MRI T2 star, remember those two are the gold standards, or by lack of decreasing of serum ferritin trend, but definitely I would recommend you verify this lack of decreasing serum ferritin trend with your FeriScan and T2 star. So in those patients, we have to consider increasing the chelator dose to a maximum of desferrioxamine, if they are on that, 50 to 60 milligram per kilogram per day, 24-hour infusion. Diferriprone, 100 milligrams per kilogram per day max, and divarasib 20 milligrams per kilogram per day. Now, some patients, despite the fact with a film-coated tablet, the gastrointestinal disturbances have become less of a problem, some patients do still experience gastrointestinal problems. And what we see is that splitting the dose may improve both the tolerability, and if we obviously improve the tolerability, then we can improve the efficacy because it will take more of it. So, and this study showed that a twice daily split dose of divarasib may be beneficial for those patients who are unresponsive or intolerant to once a day dose. So do recommend that to the patients if they come to you to say, I've been taking my 4 tablets of Xjade a day, but I can't tolerate them and therefore I don't really take them consistently, then do suggest splitting them into 2 in the morning, for example, and 2 in the evening. So dose reductions indeed may be necessary to achieve therapeutic goals. So increased chelator doses, as we said before, can increase toxicity by removing iron that is needed for normal tissue metabolism. So when the serum ferritin decreases to nearly normal levels, then we need to consider reducing the chelation dose. So we have this, with the desferrioxamine, we have this therapeutic index, which was published by Professor Porter many years ago. And essentially, we should be using that because it gives us a good guidance about where we are with the desferrioxamine dose. And the therapeutic index is the milligrams per kilogram per day of desferrioxamine divided by the average ferritin. You know, you can take the average ferritin the last sort of 3 to 6 months. So if you do this division, you should keep that fraction always less than 0.025 to be able to say that or to be reassured that the dose of the desferrioxamine you're giving to your patient is not too much. Now, that having said that, as I said so many times already today, the ferritin is not really a particularly reliable marker for everybody. So you can have a low ferritin in somebody, but actually they can have high iron burden. So this therapeutic index is good practice to use from time to time between the times when you scan your patient to measure, you know, the iron overload with the T2 star and the ferriscan, because ultimately these are the ones which are going to tell you which direction things are going. But you know, you can't, we can't scan patients every few months. It has to be, you know, once a year, or sometimes less than that. So these are things that we can use in between. Now, in terms of the deferiprone, yes, I mean, you know, you need to be looking at, so I mean, it may have decreased efficacy. We know that, again, for publications in patients with serum ferritin less than 2,500 micrograms per liter, and therefore switching to another chelator may be required. Now, in terms of the deferasirox, for serum ferritin levels consistently below 500, we should be considering either reducing or interrupting the dose to achieve iron balance. So in terms of the soft landing, so as the ferritin or the iron stores are coming down, we know that from the desferrioxamine data that this is where the toxicity problems, you know, are seen. We don't have particularly robust published data with the other chelators, but it's sometimes something that we do see in practice. So sticking to the desferrioxamine to look at that data, we know that the adverse events are more likely when the serum ferritin on desferrioxamine is less than 1,000 micrograms per liter, or with higher doses, for example, adults being on more than 60 milligrams per kilogram per day, or children being on more than 40 milligrams per kilogram per day. And things that we see in terms of toxicity in these situations is growth problems in children and hearing, sensory neural hearing loss, and vision toxicity, ophthalmic toxicity. So I'm going to skip this because it just shows you the deferiprone and the ferritin, which I just talked about. So here, safety profile of patients with ferritin of less than 1,000 micrograms per liter on deferasirox. Now, this study showed that actually those with ferritin less than 1,000 and those with ferritin more than 1,000 didn't have a particularly, you know, significant difference in terms of the development of particular side effects being on, you know, similar doses. Having said that, in practice, and there have been subsequently other randomized controlled trial studies, but other observations, and from our own experience, we know that the lower the iron burden is and the higher the dose of deferasirox is, the higher the risk is of renal damage. And in some patients, we have seen irreversible renal damage. So we've got to be careful of that. So considerations when adjusting iron chelation therapy. So high transfusion rate, action point would be to increase the dose to achieve a therapeutic goal. If we have persistent iron overload, we need to increase the dose or switch chelators. If we have patients with low transfusion rates, we need to decrease doses to achieve therapeutic goals. Low iron loading so serum ferritin less than 500, again, we have to consider decreasing or interrupting chelation and monitor and reintroduce when the ferritin goes up. We have to consider patient experiences and adverse events, and again, either reduce the dose or switch chelators. Non-compliance, so desferrioxamine, compliance with a subcutaneous infusion is a huge task, very challenging. So in some patients, it will probably be the best chelator for one or the other reason, but if they're not compliant, then we need to switch chelators. So talking now about principles and potential advantages of chelator combinations. So we may be able to accelerate iron removal by shuttling of iron from the body, so from the liver and from the heart. So with simultaneous use of more than one chelator. And so that's one potential advantage. The other potential advantage is that we may be able to avoid dose-limiting toxicity of single agents by using lower doses. For example, if you have somebody who is on deferasirox, and you know that you have to increase the dose because you're looking at the liver iron content, which is going up and up and up, but you can't do that because every time you increase the deferasirox dose, the creatinine goes up, then you need to consider whether either to switch chelation or to leave the dose in a subtherapeutic on a subtherapeutic level, but introduce a second chelator at a low dose, because the combination of them will do the job. So yes, so this is what we call really the shuttling of iron by chelators. So it's a process by which one chelator picks up the iron and donates it rapidly to another chelator, and this another chelator is the desferrioxamine, which has higher affinity but slower kinetic access to iron. So the desferrioxamine is slower to get onto the iron. So that is what can be achieved in some patients if we want to accelerate the iron removal, and this is particularly relevant in those with significant amounts of iron in the heart. So simultaneous use of deferiprone and desferrioxamine to shuttle plasma non-transferrin bound iron species unavailable to desferrioxamine has been seen both in vitro as well as in vivo to be an effective way of tackling this. And we know that there are studies which show synergistic effects of chelator combinations at removal of liver iron. And here in the right lower corner of the slide, you can see the synergy index, which was calculated in this publication. So you can see that, so the higher the synergy index is, the better, right, the outcome is. So you can see that actually we know that the synergistic index of deferiprone and desferrioxamine is high, but you can actually see that the synergistic index of the two oral chelators, so the deferiprone and Xjade, is equally high. So we need to think about combination treatments and their synergistic effects in those patients that we need to accelerate iron removal because they are at danger of life-threatening complications. And with this, really predominantly, we mean myocardial iron, or in those who can't have good amounts, good doses of one single agent. So examples of potential dose-limiting toxicities, so mild to moderate gastrointestinal disturbances with deferiprone and deferasirox, increased serum creatinine or urine protein with the deferasirox, liver dysfunction, so enzyme, so transaminitis with the deferiprone and the deferasirox, neurotoxicity with the desferrioxamine, and growth effects with the desferrioxamine. So to conclude, chelation therapy is an effective modality prolonging survival and complications. The principles of good monitoring and dose adjustment remain, so those are unshifting paradigms, but must have validated monitoring tools for this to work. And the shifting paradigm for all this from all this is that by combining chelation, it may be possible to accelerate iron removal, reduce those limiting toxicities, and achieve lower levels of iron overload long term. So thank you very much, and I'm more than happy to take any questions.
Thank you, Perla. Are there any questions? Olu, you've got a question?
Yeah, hi Perla, and thank you for the excellent talk. I have 2 questions. I'm a pediatrician, so my questions will be mainly about pediatrics. So in terms of dyspareunia rocks and the kidney complications, what is the best way to monitor them? Because some people use the estimated GFR or the urine creatine protein ratio. That's my first question. And then my second question is that we generally have monitored, but these are mainly sickle cell patients because we have lots of more sickle cell patients than thalassemia patients. Obviously, when they're on dyspareunia rocks, Novartis has said that they should be monitored. They should have ophthalmology and audiology tests before they start, and obviously yearly while they're on it. But our ophthalmologist did an audit and found that none of the patients had any complications at all. And literally, she was trying to say, well, I don't think this is worth doing anymore. And it's like, well, this is not me saying this, is the drug company saying it. So therefore, we need to continue to monitor them because we haven't seen anybody with complications. She was not very happy about that. So we said we'll try and find out whether other hospitals have had problems in terms of patients on dyspareunia rocks. They've had ophthalmology complications. And I just wondered whether you are aware of any audits or whether patients do have loads of complications.
Yeah, no, these are excellent questions. So creatinine and urine protein creatinine ratio, Olu, are the tools that we should be using for monitoring the renal function with TRCN rocks. And the creatinine is allowed to go up by 33%. I say, 30%. In the SPC is 33%. That's why I mentioned that number. But it's allowed to go by a third up compared to the baseline without you having to take any action necessarily in terms of reducing the dose. And the urine protein creatinine ratio, there isn't a magic number. It's just comparing. It's just looking at the trend. And if you have somebody whose urine protein creatinine ratio is going up, then that, even in the absence of raised creatinine, that should ring alarm bells as to whether the dose needs to be reduced. I mean, usually first is the urine protein which goes up, and then the creatinine follows. Also, another thing that we tend to forget is that X-ray can do hypophosphatemia due to phosphaturia or hyperphosphaturia. So dropping the phosphate levels, in a sort of unexplained reason, you can't explain it otherwise. Again, that's something that should ring alarm bells that maybe there is a bit of an X-ray toxicity. But standardized, well-established tools for monitoring renal function on X-ray is creatinine, so and urine protein creatinine ratio.
And when I checked, because we had this problem as well when we first started using X-Jade, was when we looked at the what was given by the drug companies, they wanted eGFR, and so basically we then had to find a calculation to be able to do that. So this is what we're doing, but we're also doing urine creatinine pressure as well, so we're combining both. So it was really difficult, I remember initially, to get the calculation for the eGFR because you need the height, you need so many other things to be able to calculate it. So what you're saying is probably a lot easier for us, but at the time the drug companies wanted the eGFR.
Yes, I mean, I think that was, are you talking about years ago?
Yeah, when we first started.
Yeah. I mean, the trend of renal monitoring and even dosing of TRCN rocks has changed a lot. From I remember I was doing the trials when it was first introduced in clinical trials, the TRCN rocks, and everything was so different back in 2006, and and it remained what you're suggesting. It remained sort of the recommendation for good 10 years after. But it's, you know, at the moment, for sure, I would be happy. And the majority of the centres who put patients on X-shade are happy with creatinine and urine protein creatinine ratio.
Okay, it makes my life a lot easier, I must say.
In terms of the ophthalmic and hearing toxicity. So again, in the trials, we've seen some cataracts, but really, and there were a couple of cases of retinal damage, I think, but really nothing significant to warrant, you know, yearly hearing and ophthalmology tests in a well chelated and stable from those you know, functions, you know, ophthalmic and hearing symptom point of view. But we do recommend, yes, I mean the recommendations still exist. They are still in place for yearly ophthalmology tests, at least. So I mean, in a child, I think things are very different, isn't it? Because you don't know. I mean, everything is even more fragile and in development. So, you know, it's very difficult to apply what we apply on the adult side. If somebody has been on X-shade for years and they've been fine, and I'm not worried about over chelation, then I would not send them for yearly ophthalmology and hearing tests. But on the pediatric side, I would at the beginning until they're well established on a good dose. But there haven't been particularly recent audits or surveys looking at those two ND-ferrosirox, as far as I know, but definitely less of a worry. I mean, if you have somebody who's had these kind of toxicities on desferrioxamine, then switching them to X-shade is definitely, you know, the way forward. I had a couple of elderly patients. You know, these side effects, the vision and hearing, is a problem because you don't know whether those, when you see those problems developing, you don't know whether it's your chelators doing them or not, and unless you have a very experienced ophthalmologist looking after these patients, and they have an interest in the chelation induced ophthalmic toxicity. And that makes it very important to have a linked ophthalmologist to look after your patient, you know, a standard person who understands what to look for in somebody on X-shade or in somebody on desferrioxamine. And I find it particularly confusing when you have elderly patients, and Bernadette knows what I'm talking about. We have a couple of elderly patients who have transfusion iron overload secondary to MDS and or myelofibrosis, and they are diabetic as well, and then we put them on chelation and they develop vision problems. And then we don't know really whether those are chelation induced or diabetes. So we know that the diabetes can make this retina blood barrier very fragile. So I think more chelation will go and infiltrate the retina in those, you know, elderly patients or diabetic patients, and therefore, you know, it's probably a combination of things, isn't it? Is there underlying pathology, fragility, as well as the chelation? So it's not easy, but you know, it's definitely good practice to monitor yearly for both, definitely on desferrioxamine and in certain patients on X-shade.
Thank you very much. I went back to Novartis just to confirm, and they reiterated what you've said, that it should be yearly. So I went back to the ophthalmologist to say, well, it has to be done. So
yeah.
Lovely, thank you. And Perla, could you just stop sharing your screen so we can see your face? Thank you.
Oh, sorry. I'm very sorry.
Question from Jane Graham in the chat. Please, can you talk about the role of vitamin C in chelation and also amlodipine?
Okay, So right, so with amlodipine, yes, I know that there've been some studies showing as a it's in relation to the calcium channels. However, this is not part of standard practice to make it part of any sort of chelation management approach. In terms of vitamin C, we know that vitamin C and desferrioxamine are very good friends. So vitamin C enhances the iron excretion through the urine if it's given simultaneously with the desferrioxamine infusion. And that's really important. So if they take the vitamin C now and they attach themselves to the desferrioxamine, tonight, that's not going to make any difference. But if they have the vitamin C at the time the infusion is up, then really this enhances significantly the iron excretion. It's less clear what the vitamin C role is with the other chelators. So I wouldn't draw any conclusions out of so obviously the three chelators work differently. But yeah, the well-established fact is that it's good practice to give vitamin C with desferrioxamine. You've got to be a little bit careful when you deal with a high myocardial iron load, because you can cause some electrophysiological damage if you give high doses of vitamin C in those patients. But you can introduce it a bit later once you've shifted out some of the iron. So you introduce your IV desferrioxamine with your diferiprone in those patients, for example, and then once things are better, you can start using the vitamin C. But yes, this is pretty much the role. I wouldn't add it to the other chelators necessarily, though, because I don't know what exactly the effects of that would be. How long does it take to see the benefits? You mean after introducing the vitamin C as opposed to the desferrioxamine? Well, I mean, things are not happening from one day to the other. Generally speaking, with chelation, is months that we need to look at. I wouldn't expect to see any differences for at least 3 to 6 months, I would say. But you do see difference. I mean, the patients will come back to you to tell you that the urine looks darker, for example, when they start vitamin C, because they get more iron excreted.
Lovely, thank you. Another question in the chat from Kirsten Lund. Is there evidence to suggest that splitting the dose of the ferrosirox will reduce the renal toxicity?
No, Kirsten, yes, I don't think there is that evidence. I mean, there is evidence, as I showed, about improving tolerability and efficacy, and that was a pediatric study. But I don't think there is anything in relation to the renal. So the renal is really a matter of being careful about the. So if we want to decrease as much as is in our control, if we want to decrease the risk of renal toxicity, it's all about making sure that, depending on their transfusion requirements and their weight, they are at a sensible, and their body iron stores, as measured by liver iron content, they are at a sensible dose, and then keep an eye on those factors that we've just said regularly. And even then, of course, some patients will develop renal toxicity. And no, there isn't. I don't think there is anything looking at that.
Thank you. Last question in the chat currently on for oral chelate, so for Xjade, or for oral intake, sorry, does tannin in tea or casein in milk affect the effect of deferrosirox?
No, I don't think they do, and they helped with the iron excretion, those dietary modifications. The same with calcium, so dairy products. So no, I don't think there is any relationship between those nutrients and or substances and efficacy of the actual chelations, interaction with them, if that's your question. But they're definitely beneficial in terms of reducing iron.
And sorry, the second part of that.
Yeah, sorry. Yeah.
No, sorry. The second part of that question was should it be taken on an empty stomach?
Which ones?
Deferocyrox.
Right. Well, they say on an empty stomach. However, it doesn't matter. It does not matter so much. What matters is that they take it. That's the pragmatic reality, right?
And that's the view I take. If they take it on an empty stomach and they feel sick and they don't take it, take it with food, take it, you know, whenever is better for them.
Exactly.
Thank you. Any other questions for the chat, or if you want to just come in and ask anything now? No, that's lovely. Then thank you very much, Perla.
Okay.
That's very helpful.
Thank you very much. Have a great Friday and a good bank holiday weekend. Bye.
Thank you very much. Thanks.
Thank you.
Bye-bye.
Bye.
Thanks, Perla. Bye.